Welcome. This presentation, entitled Genetic Testing in the Field of Oncology, Ethical and Legal Considerations, has been prepared by Kennon McCollum, a current doctoral candidate for the degree of Doctor of Nursing Practice at the University of Alabama Capstone College of Nursing in Tuscaloosa, Alabama. This program was prepared as a requirement for Nursing 740, Health Policy and Politics, Implications in Healthcare, a course which focuses on the principles of health policy and the political process as it relates to healthcare in the United States and internationally. The components of this presentation include discussions regarding particular types of genetic testing that are currently performed within the medical subspecialty of oncology. This discussion will also emphasize various issues related to the practice of genetic testing, and in addition, the viewer will be presented with an analysis of ethical and legal issues surrounding the use of genetic testing in oncology. Hopefully, the viewer will be presented with the ideas regarding the benefits and potential risk associated with genetic testing, the various ethical and legal issues that are pertinent to genetic testing, the current status of healthcare policy and law as it regards to genetic testing, and finally, through the unveiling of a particular case study, the viewer will be presented with a scenario that will demonstrate how nursing practice, nursing research, nursing education, and nursing policy formation should focus on the aspects of patients and patient outcomes which are the direct result of current genetic tests available in clinical oncology. In examining the ethical and legal issues as they may relate to genetic testing in oncology, it is important to first answer the question, what exactly is genetic testing? In knowing that the human body is dependent upon a vast collection of cells that rely on normally functioning strands of DNA to produce healthy genetic structures, we have all become reliant on normal genes to keep us healthy. Most diseases have their roots in our genetic structure and function, and according to a 2010 report from the National Cancer Institute, more than 4,000 diseases stem from altered genes inherited from one or more parents. These hereditary mutations are carried in the DNA of the reproductive cells and are passed onward into every cell of a parent's offspring. Because every cell of the offspring contains the gene defect, it is possible to use particular laboratory assays to locate these genetic mutations. The genetic tests designed to detect these mutations serve many purposes, and in oncology, these genetic tests can be used to diagnose cancer, to classify cancer into various subtypes, or to predict a patient's responsiveness to a particular treatment. In oncology, there is a vast array of genetic tests available, and currently Myriad Genetic Laboratories is the only manufacturer of specific genetic tests used in oncology that make it possible to detect gene mutations associated with the increased risk of developing cancer in certain populations. These products include a predictive medicine product for hereditary breast and ovarian cancer called BRCA-analysis, which is designed to assess the risk of developing hereditary breast or ovarian cancer based upon the detection of mutations in the BRCA1 and the BRCA2 gene. This test has become the standard of care in identification of individuals with hereditary breast and ovarian cancer. In addition to the BRCA-analysis, Myriad also makes a product to detect hereditary non-polyposis colorectal cancer, HNPCC, which is a rare inherited condition commonly known as Lynch syndrome. Doctors estimate that 3 out of every 100 colon cancers are caused by Lynch syndrome. Mutations in the MLH1, MSH2, MSH6, PMS2, and EpCAM genes are responsible for the majority of Lynch syndrome cases. Myriad Genetic Laboratories manufactures Colaris, a laboratory assay which predicts mutations in the genes associated with Lynch syndrome, and Colaris AP, which detects mutations in the APC and MYH genes, which are also associated with various other types of colon cancer. Myriad is also responsible for the production of Molaris, which detects inherited mutations in the P16 gene, which is associated with hereditary melanoma, and Panexia, which analyzes the PALB2 and the BRCA2 gene, the two most common gene mutations in families with hereditary pancreatic cancer. The detection of gene mutations through these sophisticated laboratory assay products often raises certain ethical questions, such as, what does it mean for the patient who tests positive for these mutations? Or perhaps, does the presence of a gene mutation definitively and emphatically predict that a person will assuredly develop cancer in the future? In their 1996 article entitled Legal and Ethical Issues in Genetic Testing and Counseling for Susceptibility to Breast, Ovarian, and Colon Cancer, Dickens, Pye, and Taylor describe a host of ethical concerns that emerge from the use of genetic testing to determine susceptibility to various types of cancer. They make it clear that physicians, nurses, genetic counselors, and the staff of diagnostic laboratories must remain cognizant of the ethical and legal context of genetic testing due to the fact that patients are often attentive of their legal entitlements and of the ethical responsibilities assumed by healthcare professionals. The ethical duty for healthcare practitioners regarding genetic testing include 1. The duty of full disclosure of information regarding the test in a manner that is clear and understood by the patient. 2. Disclosure of all aspects of the risk of cancer related to positive genetic susceptibility results. And 3. The absolute protection of all confidentiality matters that remain pertinent to the genetic testing and their results. These authors also describe the scope of laws that apply to genetic testing and counseling as immense and all-inclusive in regards to international human rights law on healthcare protection, and mention that these laws are often reflected throughout many segments of governmental regulation. Sharp in 1994 also mentions that liabilities arise when professionals in various fields can be held accountable for negligent statements that cause financial or other damages, and also states that it is uncertain how this principle applies to genetic counselors whose explanations of the risk associated with a positive genetic test might result in psychological harm. Other potential liability and ethical concerns are centered around issues such as genetic testing of children when a parent is found to have genetic susceptibility, genetic discrimination of patients by healthcare insurance carriers, genetic discrimination by potential employers, and genetic testing, which is used as a public health screening tool. Currently, genetic testing is expensive. The cost of testing usually ranges from several hundred to several $1,000s. Insurance policies often vary with regard to whether or not the cost of testing is even covered. In general, the cost of the test is not covered by insurance carriers unless the person being tested has a previous diagnosis of an atypical form of cancer, such as breast cancer at an early age, and a very strong family history of cancer. Patients who do not have a cancer diagnosis are typically not covered by insurance for testing. Coverage by insurance brings about the question of certain ethical issues. What about the individual with a strong and positive family history of cancer? Would it not be a benefit to those individuals to know if they have a genetic susceptibility in order to begin earlier and more rigorous cancer screening routines? What about patients who are adopted and completely unaware of any family medical history? Would these individuals benefit from knowing if they were at risk for certain types of cancers? Why must an individual be relegated to having a cancer diagnosis before insurance will offer coverage for these types of tests? These are all ethical questions with relevance in the medical arena of advanced diagnostic technology. In an attempt to solve the dilemma asked by some of these questions, Myriad Genetic Laboratories has created a self-pay program for patients whose costs exceed the amount of $375. Myriad offers patient assistance programs for helping defray the cost of some of its genetic testing. Genetic testing in the field of oncology does provide patients with particular benefits. Knowing the genetic susceptibility of patients gives direction for earlier and more frequent cancer screening processes for those with positive genetic mutations. By instituting earlier and more frequent cancer screening measures in these patients, there is the potential for early detection of future cancers. In the case of hereditary breast and ovarian cancer syndrome, HBOC, a positive test result in combination with findings for a strong family history of breast or ovarian cancer helps to guide treatment planning and provides surgical guidance with recommendations for prophylactic bilateral mastectomy, hysterectomy, and oophorectomy in select high-risk patient populations. Positive BRCA mutations may also guide oncologists in treating patients with chemotherapy in the setting of early-stage disease when chemotherapy would not otherwise be indicated in the adjuvant setting. Hereditary breast and ovarian cancer syndrome causes about 10% of breast and ovarian cancer and substantially increases the risk for developing breast and ovarian cancer before the age of 50. This chart clearly shows the risk of cancer in BRCA-positive patients as compared to those without the BRCA gene mutation. Knowing that a patient has BRCA gene mutation allows for either chemopreventative measures or surgical intervention, which may greatly reduce the risk of cancer in many women, as this chart clearly illustrates. In patients who are anxious about their genetic status or the genetic susceptibility of their offspring, a negative test result can provide peace of mind for certain patients with strong family histories of cancer and patients who are concerned about disease recurrence. In addition to the advantages of genetic testing, there are also potential risks and disadvantages. One such disadvantage is the anxiety that is created amongst patients and their families when a positive gene mutation is detected. Once a gene mutation is detected, a patient must make hard and difficult decisions regarding the test result. This often means having to decide on body-altering surgeries or surgeries which may render the patient permanently disfigured and/or infertile. These decisions often represent monumental ethical concerns related to the discovery of any abnormal oncogene mutation. The National Cancer Institute provides a comprehensive and thorough discussion regarding genetic testing on its website in order to educate patients. In addition to a comprehensive overview of genetic testing, this site also lists the advantages and disadvantages of having a genetic test performed. This website clearly states that if a gene alteration is found, it can be associated with an increased risk of getting cancer, but it will not tell if or when a cancer will develop, and if an alteration is not found, it is still no guarantee that cancer will not develop. The false sense of security that comes with negative test results remain a current concern that may cause patients to be less adherent to recommended cancer screening measures. One looming ethical concern and disadvantage in regards to genetic testing is that there is no guarantee that the test results will remain private. Because insurance companies often have access to these results, patients often face discrimination for health, life, disability, and other forms of insurance. The ethical concern over patient discrimination based upon a particular genetic susceptibility remains as cogent and as a valid ethical concern for many. Let us now look at a case study in regards to the ethical and legal implications regarding genetic testing in oncology. Let's take a moment to look at Sally. Sally is a 31-year-old female fitness instructor at her local gym. She is married and reports no other medical problems. Sally and her husband are currently waiting until he graduates from law school before they make plans to start their family. Sally unfortunately was diagnosed with a stage 2A infiltrating ductal carcinoma of the left breast at age 31 when she felt a lump during a routine self-breast exam. The pathology from her tumor revealed that it was ER positive, PR positive, and HER2 negative. In examining Sally's family medical history, it is important to note that her mother, who is of Ashkenazi Jewish heritage, was diagnosed with breast cancer at age 54, and it is also important to note that Sally's grandmother died of ovarian cancer at the age of 61. But perhaps the most revealing segment of Sally's family medical history is that one of her 3 sisters was also diagnosed with metastatic breast cancer at age 34 and is now currently in hospice due to the evidence of brain metastases and advanced metastatic disease. Sally underwent a lumpectomy procedure and completed a full course of adjuvant chemotherapy and is currently awaiting radiation. Just prior to starting radiation, her oncologist conducted both the BRCA1 and BRCA2 testing, and Sally was found to be positive for both the BRCA1 and the BRCA2 gene. In considering Sally's case, it becomes apparent that there are multiple medical, legal, and social implications. The fact that she has an extensive family history of breast and ovarian cancer, in combination with the genetic susceptibilities related to the presence of both the BRCA1 and BRCA2 genes, Sally is now at an extremely high risk for recurrent cancer in the future. The first ethical dilemma is that Sally is now considered to be cancer-free after her surgery and chemotherapy. The dilemma that arises is in knowing that Sally must now consider removal of both of her breasts and undergo a total hysterectomy with bilateral oophorectomy as a cancer prevention and prophylactic measure. This news is devastating for Sally after choosing a breast-sparing procedure and undergoing months of chemotherapy. Not only was she certain that her cancer was in remission, but she was also certain that her surgical interventions were over and that her body was left intact and that she still had taken measures which preserved the ability for her to have a family in the future. Because of these and many other issues, certain questions are raised regarding the ethics in Sally's case. These questions include: why was Sally's primary care physician not more active in beginning early mammogram screenings given her high risk of family history? Why was Sally not offered her BRCA at the time of her initial breast biopsy when the surgical decision for lumpectomy was made? Was Sally's surgeon negligent in not determining her BRCA gene status before recommending a lumpectomy? Would knowing Sally's BRCA status before her lumpectomy saved her from having to undergo further surgeries? Should Sally have a bilateral mastectomy at all given her previous choice to have a breast-sparing procedure? Should Sally plan on delaying her oophorectomy until she has her children, or go ahead and perform her surgery now given her high-risk status? Should Sally even have children at all, knowing that they have a strong chance of also carrying on her genetic mutations? Other legal and social questions could also include: in the future, does her BRCA status place her at risk for discrimination from health, life, or other types of insurance carriers? Should future insurance carriers have the right to know Sally's health history and status at all? And perhaps the most thought-provoking question of all would be to imagine that Sally did not even have a history of breast cancer, and then to ask yourself the same questions. Would the answers to any of these questions change? The questions that arise from Sally's case from an ethical and social perspective are profound. And knowing that 5 to 10% of all breast and ovarian cancers are related to inherited genetic mutations in the BRCA1, BRCA2, TP53, or the P10 gene, and that currently there are assays that detect mutations in 2 of these genes, it becomes an implied imperative that the possibility of mutations in these genes should be explored in women with a very strong family history of these types of cancers. By combining the fact that 15 to 20% of women with strong family histories of cancer that do not have genetic mutations develop breast or ovarian cancer, with the fact that the presence of one of these gene mutations predicts as much as 30% the likelihood of developing cancer, genetic testing should have been explored much sooner in Sally's case. Sally's primary care physician, and knowing that Sally had the risk factor of being an Ashkenazi Jew, a mother and sister who have breast cancers that were diagnosed at an early age, and a grandmother who died of ovarian cancer, Sally should have been considered for early mammography screening measures. Since the BRCA1 gene was first mapped on chromosome number 17 in 1990 and was subsequently cloned in 1994, followed by the BRCA2 gene, which was also mapped and cloned in 1995, giving rise to the development of commercial laboratory assays for detecting mutations in these genes, testing has become a standard of care in high-risk populations based upon family history. And knowing that family history should guide earlier mammogram screenings, and positive genetic mutations easily detected from laboratory assays should guide prophylactic surgical considerations, both earlier screenings and more aggressive surgical interventions should have been taken into consideration in regards to Sally's case. In looking at genetic testing just within the field of oncology, there are some particular ethical concerns that are unique to the field of oncology. For example, what about men with an inherited BRCA gene mutation? Although breast cancer in men is not as common as it is in women, men with mutations of either the BRCA1 or BRCA2 genes often have higher rates of breast cancer than men without any gene alteration. It is known that men with inherited BRCA gene mutations are at a higher risk of developing other types of cancers different from breast cancers. Even if a man never develops cancer, he can still pass his gene mutations onward to his sons or daughters who are then at higher risk for developing cancer in the future. The testing of children becomes an ethical issue within itself and raises several ethical questions such as, should we test the offspring of gene-mutated parents before they develop cancer, or should testing be held until after cancer develops? An example of this particular ethical dilemma was displayed in Sally's case in addition to the question of proper administration of informed consent and a full disclosure of all aspects of the risk of cancer related to positive genetic susceptibility. In her case, would Sally's outcome have been different if earlier genetic testing would have been performed? or if Sally would have been informed of her genetic status before making the choice to have a breast-sparing lumpectomy. Would her genetic status have possibly influenced her decision to have children sooner, or even to have children at all? In considering the many ethical aspects of any genetic testing issue, it becomes important to look at the whole of genomic science from its inception. The Human Genome Project was initiated in 1990 as a branch of the National Institutes of Health and the Department of Energy for the purpose of creating a complete genetic map of all human genes. This gene mapping and sequencing project has led to the identification of many of the genes responsible for particular disease states and consequently has given rise to laboratory assays that can identify particular genes and any mutations associated with their existence. Out of public concern for the project, the Ethical, Legal, and Social Implications (ELSI) program was formulated for the purpose of examining the potential social and bioethical consequences that may result from human genetic study. As a result, a total of 5% of the Human Genomes Project budget was translated into the ELSI program, making it the first federally supported research initiative in biomedical ethics and the largest source of public funds for genetic ethics research. This program is now referred to as the National Human Genome Research Institute's Ethical, Legal, and Social Implications Research Program and was established in 1990. The ELSI program set out to establish ethical practice standards regarding all human genetic bioethical research and to anticipate and address the implications for individuals and society that may happen as the mapping and sequencing of the human genome is successfully accomplished. The ELSI program also stimulates public discussion and debate of the issues related to human genetic study and develops policy options to assure that information obtained from human genetic study will be used for the benefit of individuals as well as society as a whole. When considering legal protections for the public in regards to human genetic research and testing, it is noted that prior to the 1970s, no U.S. legal precedent existed in regards to human genetic testing. Legal precedent was first set in the 1970s regarding informed consent and failure of disclosure in regards to forced genetic testing, when several insurers denied coverage to African American individuals who tested positive for the gene for sickle cell anemia. Recent precedent civil cases regarding genetic testing occurred when the Lawrence Berkeley National Laboratory in California secretly tested workers for sickle cell trait and other genetic disorders starting in the 1960s and continued to do so until 1993. The laboratory was cited for ethical violations because the workers were not informed of the genetic testing and were told that the blood that was being collected was for routine cholesterol screenings and for other routine medical reasons. Another case involving the Burlington Northern and Santa Fe Railway Company involving 36 employees in which the workers claimed the company sought to genetically test them without their knowledge after they had submitted work-related injury claims was settled out of court for the sum of $2.2 million in 2002 when the company refused to acknowledge that genetic testing had even occurred. As the result of various precedent-setting litigation lawsuits that surfaced in the latter half of the 1990s, the American Management Association published the results of a survey conducted in 1991 among nationwide companies in regards to their practices concerning the medical screening and testing of potential new employees. Their study revealed that amongst these companies, 14% conducted tests for susceptibility to workplace hazards, 3% conducted tests for breast and colon cancer, 1% conducted tests for sickle cell anemia, and 10% collected information about family medical history. In fearing that employee workplace discrimination was occurring as a result of these tests, Congress began efforts to pass legislation to protect citizens from unwarranted and forceful genetic testing for the purpose of job discrimination. Due to the efforts of several congressional committees on the practice of pre-employment genetic testing, legislation was introduced on May 21, 2008, and was signed into law by President George W. Bush, and was entitled the Genetic Information Non-Discrimination Act, or GINA Act. This act prohibits U.S. insurance companies and employers from discriminating on the basis of information derived from any genetic test. This legislation, which passed both the houses of Congress with a vote in the U.S. House of Representatives of 414 to 1 during the 2008 session, now makes it illegal for insurance companies and employers to discriminate based upon information derived from genetic testing. This legislation also prohibits insurance companies from discriminating through reduced pricing or coverage based upon genetic susceptibility testing. Additional protections prohibit employers from making any employment decisions based upon genetic testing and prohibits employers from requesting or demanding that genetic tests be performed. With the passage of the Genetic Information Non-Discrimination Act in May of 2008, we now have certain protected rights as individuals in regards to genetic testing. This act protects us against insurance and employment discrimination based upon genetic susceptibility that is detectable through any form of genetic testing. This same act also prevents the forceful testing of individuals for genetic screening against their own willing participation. But what about the issue of government-sponsored population-based genetic screening? Should the government have the right to conduct mass population screenings for the purposes of identifying groups of individuals who are at risk for disease based upon an identifiable gene mutation? What about the future? What types of legislation become important for us as individuals in regards to government-based genetic testing efforts? In addition to GINA, other regulations and legislation will most assuredly be needed in regards of protecting the public in the future from bioethical dilemmas related to oncologic genetic screening. As technology advances and genetic testing becomes more readily available, the possibility of population-based oncologic genetic screenings may become a reality. Currently, no federal policy has been undertaken which addresses the issue of population-based screenings of oncologic genetic disease. Before population-based screening for genetic conditions occur, programs should ensure that several essential points are included. These points include: Number 1. The screening must remain strictly voluntary. Number 2. Screening programs must clearly and understandably state their purpose and goal. Number 3. Peer-reviewed studies must be incorporated to demonstrate that the stated goals of the program can be achieved at a reasonable cost and with minimal adverse effects. Number 4. Target populations must be educated about the disease or condition in question and receive counseling about the risk and benefits of screening. Number 5. Traditional standards of informed consent must always be observed. And finally, and above all else, measures of confidentiality of the individual and their genetic susceptibility must be strictly maintained. With the growing popularity of genetic testing, we must ask the question, what about the role of nurses in regards to genetic testing? As nurses in the U.S. healthcare system, it is important to realize that currently in the United States, there are no regulations currently in place for evaluating the reliability and accuracy of genetic testing. Nurses should also be aware of the fact that only a few states exercise regulatory oversight of genetic testing. Nurses need to remain vigilant in knowing that the Food and Drug Administration, FDA, does not regulate many of the genetic tests that are currently available, and that this lack of oversight is in part due to the fact that the majority of genetic tests developed by laboratories are categorized as services, which falls outside the jurisdiction of federal regulation. Because of the lack of government oversight, nurses should become educated on the aspects of legitimate genetic testing, and nurses should utilize self-education to learn which companies are marketing genetic test kits available directly to the public with uncertain claims about how these test kits not only test for disease, but also serve as tools for customizing medicines, vitamins, supplements, and other claims for cures that are customized to each individual's genetic makeup. Nurses should act as advocates for patients in regards to genetic testing, and nurses should ensure that patients seek out proper genetic counseling to help with the interpretation of any genetic test result. Nurses should also recognize that only persons specially trained in genetic counseling should be making life-changing recommendations and interpretations for patients in regards to genetic testing. Castles et al. 2002 note that it is important to recognize that nurses are patient advocates that are tasked with being the managers of genetic information, who also act as the safekeepers of privacy and confidentiality in regards to genetic testing, all while serving as the recorders of potential problems when documenting genetic information. In quoting Feathan, Thompson, and Henshaw, 2006, who state that the genomic era provides significant opportunity to improve leadership for nursing healthcare, public health, and health policy, it becomes apparent that the future of nursing research in regards to genetic testing will serve to increase nursing visibility in the area of genetic science. Nursing will do this while providing a valuable perspective to the contribution of improved patient care and outcomes as they relate to this new and emerging technologically advanced science. Currently, nurses should remain champions and guardians of current healthcare policy that serves to protect patients and the public when care becomes focused on genetic susceptibility identified by genetic testing. First, nurses should recognize that the 1996 Health Insurance and Portability HIPAA Act provides protection to individuals in terms of their group insurance and health plans by preventing any individual with genetic susceptibility from being denied coverage or suffering from increased premium rates because of any pre-existing condition, including those of a positive finding from any genetic test. Nurses should also be aware that the Employment, Retirement, and Income Security Act, ERISA, protects patients from health insurance discrimination. And finally, nurses should know that the Genetic Information Non-Discrimination Act, GINA, prevents employers from using genetic testing information as a basis for discrimination in the workforce. And this act also prevents employers from forcing individuals from being forced into submission and taking a genetic test involuntarily. In summarizing the ethical and legal issues surrounding the use of genetic testing in oncology, we must recognize that genetic testing is gaining momentum in today's healthcare and will soon become commonplace in terms of routine practice. In oncology, this genetic testing serves to predict the possibility of future cancer. Because of this, we have to recognize that many ethical issues surround the use of genetic testing in oncology, and that this technology must be utilized with the tenets of good stewardship in regards to medical ethics. This good stewardship is essential because of the improper use of genetic testing in the past that thankfully brought about federal regulation reform that now offers protection in regards to genetic testing in the form of the Genetic Information Non-Discrimination Act. It is equally important to recognize that genetic testing is a relatively new science and that currently population genetic screenings are not routinely performed, all while recognizing that the possibility of population-based genetic screening for oncologic disease does exist in the future. Above all else, nurses must educate themselves regarding genetic testing, must act as advocates for patients in regard to genetic testing, and further the science of medical genomics by becoming involved in nursing research as it pertains to the very complex science of genetic study. Thank you, and I hope you enjoyed this presentation regarding the ethical and legal considerations of genetic testing in oncology.